Hello everyone, welcome to my channel Anatomy by Dr. Vijaya. So this is the series of videos covering up the nerves of the upper limb and nerve injuries. In my previous video I had discussed about the brachial plexus. So the formation of brachial plexus, what are the different parts of the brachial plexus and their branches, and the clinical aspects related to brachial plexus. So in this video I am going to focus on the median nerve, which is one of the terminal branch of brachial plexus. So the anatomical aspects of the median nerve, what structure it supplies, and its clinical aspects. So as you all know, median nerve is one of the terminal branch of brachial plexus. So if you are talking about the origin of median nerve, so it gets the contribution from both the cords, the lateral and the medial cord. So the lateral cord gives a branch called as lateral root of the median nerve, and medial cord the medial root of the median nerve. So these two branches will join to form the median nerve. So lateral cord has many branches and also the medial cord. So one of the branches are lateral and medial branches. So these two branches will join to form the median nerve. So these are the root values of the median nerve, since the contribution is both from lateral and medial cord. So it receives the fibers from C5 to T1. Moving on to the structures or area innervated by the median nerve, it includes all. So if you see median nerve, though it is from arising from the infraclavicular area, so it doesn't have any innervation in the arm region, either in the anterior compartment or in the posterior compartment of the arm area. So once it comes to the forearm, it gives the major branches to all the muscles of the forearm. There are some exception, and also muscles of the hand. So these are the structures. So it mainly supplies muscles of the anterior compartment of the forearm, all the muscle except these two, which is flexor carpi ulnaris and medial half of flexor digitorum profundus. Then moving on to the hand, so it supplies 5 intrinsic muscle, that is the thenar half of the palm area, then lateral half of the palm and digital branches to palmar surface of the lateral 3.5 fingers, and also it gives articular branches to the joints, which includes elbow, wrist and the carpal joints. So this is in general the structure or area innervated by the median nerve. So we will go in detail about its course and about its branches. So median nerve formation, union of lateral root of lateral cord and medial root of medial cord. So since the contribution is from two cords, so its root value will be C5 to T1. The branches mainly includes in the forearm and the hand. No branches in the arm region. So in the forearm it supplies all the muscles of the forearm, that is the flexor compartment of the forearm or anterior compartment of the forearm, except two muscles. So it also gives articular branches, that is in the forearm, to the elbow joint. So if you see muscular branches, so it supplies 6.5 muscles, that is mainly to the flexors of the forearm. So those 6.5 muscles includes pronator teres, flexor carpi radialis, flexor digitorum superficialis, then palmaris longus, then lateral half of flexor digitorum profundus and pronator quadratus. So these 6.5 muscles are supplied by median nerve, except medial half of flexor digitorum profundus and flexor carpi ulnaris. So these two muscles are supplied by ulnar nerve. Okay, the rest are by the median nerve. Then it also gives a cutaneous branch, which mainly supplies the skin of the lateral side of the palm area. So that cutaneous branch is called as palmar cutaneous branch. Then moving on to the hand area, so it gives muscular branches to the thenar muscles. So there are thenar group of muscles, which includes flexor pollicis brevis, then it includes opponens pollicis, then abductor pollicis. So all these there is 3 thenar muscles are supplied by median nerve, and first and second lumbricals. Then it also gives cutaneous branch, that is digital cutaneous branch, to supply the lateral 3.5 fingers. So these are the main structures innervated by the median nerve: the cutaneous branches, muscular branches, and articular branches. So the picture shows all the muscles supplied by the median nerve. So this is in the forearm. So all the flexor muscles except the medial half of flexor digitorum profundus and flexor carpi ulnaris. So rest of them are supplied by median nerve. So this is in the hand, the thenar group of muscles, which includes opponens pollicis, then abductor pollicis brevis, and flexor pollicis brevis. So this is abductor and this is flexor pollicis brevis. So these are muscular branches. Then cutaneous branches, one is palmar cutaneous branches, so which supplies the lateral half of the palm area, so which is represented yellow here, yellow in color. Then once it reaches the hand, it gives digital branches, digital cutaneous branches, which supplies at the palmar aspect the lateral 3.5 fingers. So you can see here these 3 fingers are mainly the cutaneous supplies by median nerve, and also in the dorsum area, the dorsum of the hand, it supplies near the nail bed, that is the lateral 3 fingers you can see here. So near the nail bed, it is mainly by the cutaneous branches, digital branches from median nerve. So this schematic line diagram shows the branches, the origin and the course of the median nerve, and also the main branches of the median nerve. So these are the root value for the median nerve, and then it passes through the arm. So it lies beside the brachial artery. So you can see here. So it gives no branches in the arm area. So then it enters, it forms a content of the cubital fossa. So it enters the cubital fossa medial to the brachial artery, then exits by, then comes to the forearm. So it exits by passing between the 2 heads of pronator teres. So pronator teres, which is taking its proximal attachment from the medial epicondyle. So it has 2 heads. So between the 2 heads of pronator teres, the median nerve exits from the cubital fossa and enters the forearm. So it near the elbow joint, the median nerve gives articular branches to supply the joint, and also it gives branch to the pronator teres. So which is at the level of elbow joint, it gives branches to the pronator teres, and as it runs distally, it gives other muscular branches to supply the superficial flexors of the forearm, which includes flexor carpi radialis, palmaris longus, and flexor digitorum superficialis. Then it gives a branch called as anterior interosseous nerve. So this is a branch which runs distally on the interosseous membrane along with the artery called as anterior interosseous artery, which is a branch of ulnar artery. So anterior or above the interosseous membrane, you will be seeing 2 important neurovascular structure. One is a branch from median nerve, that's the anterior interosseous nerve, and an artery, that's a anterior interosseous artery, which is a branch of ulnar artery. So this anterior interosseous nerve supplies the muscles of the deep flexors of the forearm, which includes flexor pollicis longus, lateral half of the flexor digitorum profundus, and pronator quadratus. Okay, so these are supplied not directly from the median nerve through a branch of the median nerve, that is anterior interosseous nerve, but these muscles are getting branches directly from the median nerve. Then it also gives palmar cutaneous branch which supplies the lateral half of the palm area. So this is given just above the wrist joint. So at the distal part of the wrist joint, the distal part of the forearm, it gives a palmar cutaneous branch. So this arises in the forearm just proximal to the flexor retinaculum, and mainly distributes to the skin of the central part of the palm, mainly the lateral part. Okay, and once it reaches the hand area, so here it gives muscular branches to the thenar muscles, the three thenar muscles, that is abductor pollicis brevis, flexor pollicis brevis and opponens pollicis, and two lumbricals, the first two lumbricals, and also it gives cutaneous branch, that is palmar digital branches to lateral 3.5 fingers. So here when the median nerve is passing, so as I mentioned, once it exits from the cubital fossa, it passes between the two heads of the pronator teres. So this point is very important. Okay, when we are talking about the clinical aspects, there I'll be going in detail. So you need to know that median nerve passes between the heads of the pronator teres. Then it descends in the facial plane between the flexor digitorum superficialis and profundus. Then it goes deep to the palmaris longus tendon. Then as it approaches distal to the forearm, so you have a retinaculum, a thick connective tissue which holds the tendons in position. So there is a retinaculum called as flexor retinaculum, and that forms a tunnel that's called as a carpal tunnel. Okay, so there is a tunnel through which the tendon passes, and there are even the median nerve passes within this tunnel. So that tunnel is called as transverse carpal tunnel. So you need to know this. So one is passing between the two heads of pronator teres. The other one is when it reaches the hand, it passes through the carpal tunnel, that is below the flexor retinaculum. So when it is passing, so if you see here, so the anterior interosseous nerve, which is a branch from median nerve, so it just supplies, so it is present only in the forearm area and supplies the deep flexors of the forearm. Then it doesn't descend to the hand area. But palmar cutaneous branch, which you can see here, which is given at the distal part of the forearm. So this branch of the median nerve passes superficial to flexor retinaculum. Okay, so the main median nerve passes deep to the flexor retinaculum, but the palmar cutaneous branch passes superficial to the flexor retinaculum. So these points are very important. We will go into detail when we are talking about the clinical aspects. So the thenar eminence which you see on the palmar aspect of the hand, so that thenar eminence is due to the presence of thenar group of muscles, which includes abductor pollicis brevis, flexor pollicis brevis, opponens pollicis and adductor pollicis. So the name pollicis only suggests that it tells that these muscles are mainly acting on the thumb. Okay, so any muscles which are acting on the thumb are referred as pollicis. Okay, so these are the muscles which forms the thenar eminence. So under these thenar muscles, the first three are supplied by median nerve, but adductor pollicis it is innervated by ulnar nerve. So these are the intrinsic muscles of the hand at the thenar area. So now you have come to know what's the course of the median nerve and what are its branches and which structures it mainly innervates. So moving on to the clinical aspects, median nerve palsy, which can occur like if there is any injury or any compression to the nerve can cause palsy, which might mainly affect the flexor muscles of the forearm and also the palm and the digit areas. So if you see the mechanism of median nerve palsy, it can be due to supracondylar fracture. So supracondylar, that is the area above the elbow joint, so the part of the lower part of the humerus. So if there is a fracture, that's called a supracondylar fracture of the humerus. So there can be injury to the or compression on the median nerve. Then the other common cause can be due to pronator syndrome. So when I was explaining the course of the median nerve, if you can remember that median nerve passes through the between the heads of the pronator teres. So there can be a nerve entrapment syndrome which is caused by the compression of the median nerve near the elbow. So it is mainly due to the nerve gets compressed between the heads of the pronator teres. It can be due to a trauma or any muscular hypertrophy or due to a formation of a fibrous band. So this can cause compression on the median nerve, and this is called as pronator syndrome or entrapment of median nerve between the heads of pronator teres. And the most common one is the carpal tunnel syndrome. As I had mentioned that median nerve, when it is exiting from the forearm to enter the hand, it passes deep to the flexor retinaculum. That's, it mainly passes through a tunnel called as carpal tunnel. So if there is any pathology related, because through this tunnel not only the median nerve passes, there is also presence of tendons. The tendons of the forearm, they pass through this tunnel to get its distal attachment to the digits of the hand. So whenever there is any condition affecting these tendons, so there can be compression on the median nerve. So this syndrome is called as carpal tunnel syndrome. So these are the few mechanisms which can injure or cause compression on the median nerve, and that will be called as median nerve palsy. So whenever the median nerve is affected, so when the median nerve is severed, for example, if it is severed in the elbow region, so either can be due to supracondylar fracture or any injury near the elbow joint. So this will mainly affect the proximal interphalangeal joints of the first, second and third digits. Okay, so here you can see, as you know, that median nerve is the principal nerve of the forearm and mainly supplies the flexors of the forearm, which includes flexor, the two main muscles which mainly goes into the digits, that is the interphalangeal joint, as the flexor digitorum superficialis and the flexor digitorum profundus. So as you know, flexor digitorum superficialis mainly gets its distal attachment to the middle interphalangeal joint. Okay, so it splits into two and gets inserted into the middle phalanges from second to fourth digits, the four fingers. Okay, so it divides into four tendons which passes through the tunnel, and then as it approaches the middle phalanx, it splits into two and gets inserted into that. So the flexor digitorum superficialis, its main function is to conduct flexion at the interphalangeal joint, that is the proximal interphalangeal joint, which is here. So this is the proximal interphalangeal joint. So flexion of the proximal interphalangeal joints of second, third, fourth and fifth finger is mainly helped by flexor digitorum superficialis. And flexor digitorum profundus, it gets inserted into the distal phalanges. Okay, so it also splits into four tendons. The medial half two tendons which goes to the ring finger and the little finger. So those two tendons are supplied by ulnar nerve, and lateral two tendons of flexor digitorum profundus, which is going to the index and the middle finger, it is supplied by median nerve. So it mainly gets inserted into the distal phalanges and helps in flexion of the distal interphalangeal joint. So this crease mainly represents the distal interphalangeal joint, and this one is for the proximal interphalangeal joints of the second to fifth finger. So this crease mainly represents the metacarpophalangeal joints. Okay, so these joints you need to know. So digitorum superficialis mainly helps in flexion at the proximal interphalangeal joints, and profundus mainly helps in the flexion of distal interphalangeal joints. So when a median nerve is severed in the elbow region, so the flexion of the proximal interphalangeal joint from first to third digits is lost. Okay, because for the index finger, for the middle, then ring finger, it's mainly by the flexion at the proximal interphalangeal joint is by the flexor digitorum superficialis. So first to third digit, the flexion at the proximal interphalangeal joint will be affected. But for the fourth and the fifth digits, which is here, the fourth and the fifth digit, it is not much affected. There will be weakness, because that will be helped by the lumbricals and other muscles, the hand muscles. So there will be weakening of the flexion of the proximal interphalangeal joint, but there won't be complete loss. So complete loss mainly, that is the flexion of proximal interphalangeal joint is means it is lost for the first, second and the third digits, and the flexion of the fourth and fifth digits is weakened. Then because median nerve supplies digitorum superficialis, that's why the proximal interphalangeal joint flexion is affected. Now median nerve also supplies flexor digitorum superficialis, flexor digitorum profundus. So which two, as you know, profundus also splits into 4 tendons. So lateral 2 tendons is by median nerve. So that's why flexion of the distal interphalangeal joints of second and third digits is lost, but flexion of the distal interphalangeal joint of fourth and fifth digits is not affected, because medial part of the flexor digitorum profundus which produces these movements, it is supplied by ulnar nerve. So these things you have to remember. So wrist, so if the median nerve lesion is seen at the elbow region and also in the forearm areas, so which can be due to supracondylar fracture, or it can be due to pronator syndrome. Okay, so the forearm is kept in the supine position. Okay, there will be no pronation because pronators are affected, pronator teres and pronator quadratus are affected. Wrist flexion is weakened because wrist flexion is mainly helped by flexor carpi ulnaris and flexor carpi radialis. So radialis will be paralyzed due to no innervation, but ulnaris will be intact. So that's why the wrist flexion is weakened, not completely lost. There will be wasting of thenar group of muscles because all those, so if it is a chronic condition, you can see the wasting of the thenar group of muscles because the muscles are not powerful for action. So there will be wasting in the thenar eminence. No flexion at the interphalangeal joints of the index and middle fingers. So here you have to remember no flexion, that is in the proximal and the distal interphalangeal joint of index and the middle finger. But for the little finger and the ring finger, it won't be much affected. Okay, because digitorum profundus is intact because that is supplied by ulnar nerve. When the patient tries to make a fist, so you can see here, you can test the whether the patient is having median nerve injury, whether the patient is having weakening or the paralysis of the muscles. So you can ask the patient to try to make a fist. So when you ask the patient to make a fist, the index and the middle finger tend to remain straight, so they will remain at the extended position. Okay, and the other two, that is the middle and the the ring and the little finger will be flexed. Okay, so this sign is called as sign of benediction. So when the person attempts to make a fist, second and third fingers remain partially extended. Okay, so hand of benediction, but there will be flexion at the ring and the little finger. Then flexion of the terminal phalanx of the thumb is also lost because flexor pollicis brevis is supplied by median nerve, which is one of the thenar group of muscle. So since that is affected, so there will be loss of flexion of the terminal phalanx of the thumb. So thumb has only 2 phalanges, proximal and distal. Other fingers have 3 phalanges, so you have to remember that. Okay, then there will be, so these are muscular branches which are affected. Then there will be loss of sensation on the lateral half of the palm because there will be palmar cutaneous branch is also affected, and there will be loss of sensation to the lateral 3.5 fingers on the palmar aspect. Okay, so loss of sensation on the lateral half of the palm, lateral 3.5 fingers on the palmar aspect, and as you had seen in the previous picture, the median nerve also gives cutaneous branches to the dorsum, that is near the nail bed. So distal part of the dorsal surface of the lateral 3.5 fingers is also affected. So these are the things you need to remember whenever there is median nerve injury at the elbow region or above the elbow or in the forearm region, which can be due to supracondylar fracture or which can be due to pronator nerve syndrome. Okay, so these are the different conditions. Now imagine that median nerve is not affected anywhere in the elbow joint or in the pronator teres area, but if there is anywhere in the forearm region which is affecting the anterior interosseous nerve. So whenever there is injury to the anterior interosseous nerve, so what happens here, the thenar muscles are unaffected, okay, because anterior interosseous nerve doesn't supply any doesn't give any muscular branches in the hand. So anterior interosseous nerve mainly supplies the deep flexor group of muscles, which includes flexor pollicis longus, flexor digitorum profundus, that is lateral half, and pronator quadratus. So that's why the thenar muscles won't be affected, because thenar group of muscles are getting the branches directly from the median nerve, where median nerve passes deep to the flexor retinaculum within the carpal tunnel. So there will be that is thenar muscles are unaffected, but there will be paresis, that is weakness of the flexor digitorum profundus, flexor pollicis longus, which will occur because which is getting the branch from the anterior interosseous nerve. So when the person attempts to make the OK sign opposing the tip of the thumb and the index finger in a circle or a pinch posture of the hand, it will result, instead of there will be absence of flexion in the interphalangeal joint of the thumb and distal interphalangeal joint of the index finger, because, and this syndrome is called as anterior interosseous syndrome. Okay, so please remember, anterior interosseous nerve gives muscular branches to flexor digitorum profundus, which lateral to flexor digitorum profundus. So what's the action of flexor digitorum profundus? Flexion at the distal interphalangeal joints. So that's why there will be loss of flexion at the distal interphalangeal joint of index and the index finger and the middle finger. Okay, the next, it also supplies flexor pollicis longus. So flexor pollicis longus mainly helps in the flexion of the thumb. Okay, the flexion of the thumb. So this will be affected since it is not getting any innervation from the anterior interosseous nerve. So that's why the patient will have absence of flexion of the interphalangeal joint of the thumb due to the paralysis of or weakness of the flexor pollicis longus, and distal interphalangeal joint due to the joint of index and the middle finger due to paresis of the flexor digitorum profundus, that is lateral to flexor digitorum profundus. It also affects the pronator quadratus, but the pronation is not much affected because it will be helped by pronator teres, okay, which is getting directly the supply from median nerve. So that won't be affected much. So this syndrome is called as anterior interosseous syndrome. Then the other presentation is ape hand. So this is also a median nerve palsy if it occurs at the wrist area. So sign of benediction can be seen whenever there is medial nerve injury in the elbow or in the forearm region. If there is injury at the wrist area, so this causes paralysis of the thenar muscles, which eventually, if it is a chronic condition, eventually it can lead to wasting, and the opposition and flexion of the thumb are lost. So the thumb and the index fingers are arrested in the adduction and hyperextension position. So you can see here. So this is the thenar area, the thenar eminence, which is formed by the thenar group of muscles. So thenar group I have already mentioned. The muscles are the flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis, which are supplied by median nerve, except adductor pollicis, which is supplied by ulnar nerve. Okay, so since adductor is not affected, so that's why the thumb will be in the adducted position. Okay, so it will be arrested in the adduction and hyperextended position because there is no flexion due to the paresis of flexor pollicis brevis. Okay, so that will be weakened. Okay, so opposition will also be affected because opponens pollicis is affected. So opposition and flexion of the thumb are lost, and thumb and index finger are arrested in adduction and hyperextension position, and there will be wasting of the thenar eminence. So this looks like a ape hand. So if you see a gorilla or a ape hand, so it cannot do it. If you see, the thumb will be in an adducted position and hyperextended. So this looks like a ape. So that's why it is referred as ape hand deformity. So whenever there is median nerve palsy, there will be two types of deformity. One is sign of benediction, which occurs whenever there is injury in the forearm or the elbow area, and ape hand deformity, which will be seen if the injury is at the wrist area. So this picture shows the carpal tunnel. Okay, so here this is a tunnel. So carpal ligament covers the concavity forming the carpal tunnel. So here you can see the retinaculum, the flexor retinaculum, which holds, this is the thick connective tissue which holds the tendons, which is extending to the hand, that is mainly digitorum profundus and digitorum superficialis, so which passes through this tunnel. Okay, and also the median nerve passes through this. So contents are flexor tendons with their synovial sheaths and the median nerve. So these are the contents of the carpal tunnel. So the other presentation is carpal tunnel syndromes. So the cause is unknown, but often it occurs whenever there is repetitive stress on the wrist area. So usually if you are continuously using your laptop, so you keep your wrist on the table, so continuously if it is compressed for a long duration, so this can cause stress on the tunnel, and a repetitive stress syndrome that can cause pressure on the median nerve in the carpal tunnel. Okay, or any synovitis. As you know, the tendons are surrounded by synovial sheath, so any inflammation of the tendons or inflammation within the synovial sheath, so this also can cause compression on the median nerve, and this condition is called as carpal tunnel syndrome. So this results in numbness, tingling sensation and burning sensation, and eventually it can lead to weakness and atrophy of the thenar muscles and lateral 3.5 fingers. So as you know that median nerve, as it passes through the under the flexor retinaculum within the carpal tunnel, it supplies the thenar muscles, the three thenar muscles and the lumbricals, and also it gives digital cutaneous branches. Okay, so which supplies the lateral 3.5 fingers. So whenever there is compression in the median nerve, so these structures are affected, but there is no loss of sensation at the palmar region, because when I was mentioning about the course of the median nerve, the palmar cutaneous branch, which is given at the distal part of the forearm, so it passes superficial to the flexor retinaculum. Okay, so since palmar cutaneous goes superficial to the flexor retinaculum, so that is not, it is spared. Okay, so it's not affected, so there is no loss of sensation at the palmar area, but you can see loss of sensation or what do you say, the tingling or burning sensations, numbness in the digits, that is the lateral 3.5 fingers, but not in the palmar area. So here you can see this part is mainly by the palmar cutaneous branch, so which is not affected. Okay, so it passes superficially. Okay, but these fingers are affected, so there will be because this is through the digital branches which is given by the median nerve after it passes through the tunnel. Okay, even these areas are affected. Okay, and you can also see the wasting of the thenar muscle. So this doesn't happen suddenly. Eventually there will be wasting, but the initial symptoms are numbness, tingling and burning sensations. So to summarize the effects of the lesion or injury of the median nerve, so it depends on the level of the site of lesion. So if it is in the elbow, so it can be due to supracondylar fracture of humerus or pronator syndrome, where there can be entrapment. So there will be paralysis of all the muscles supplied by median nerve in the forearm and palm, and also there will be sensory loss. And so this will result in motor effects, that is loss of flexion at the interphalangeal joints. Okay, loss of pronation, and when you ask the patient to make a fist, so they have difficulty to flex the interphalangeal joint and of the index and the middle finger, but the ring and the little finger will be normal. Okay, so that deformity is called as hand of benediction deformity, which is due to the paralysis of both superficial and deep flexors of the middle and the index finger. Okay, so loss of flexion at the proximal interphalangeal joint and distal interphalangeal joint, and there will be paralysis of flexor pollicis longus, which also results in loss of flexion of the thumb. So injury at the elbow, so paralysis of it. If there is an injury, it also affects the lateral two lumbricals, resulting in inability to flex the lateral two metacarpophalangeal joint. As I mentioned, that metacarpophalangeal joint, flexion at the metacarpophalangeal joint is assisted by lumbricals. So if the lumbricals are paralyzed, so there will be difficulty in flexing the lateral two metacarpophalangeal joints. Then ape thumb or simian hand deformity, it is due to the paralysis of thenar muscles. So in this deformity, the thumb comes to lie in line with the other fingers, and there is thenar atrophy producing ape thumb deformity. Okay, so this is more obvious whenever the median nerve is injured either in the wrist area or distal part of the forearm. Okay, it can also affect if the nerve is injured above as well, proximal area as well. Sensory effects: injury above the origin of palmar cutaneous branch results in loss of sensation over the central part of the palm, lateral half of the palm, and lateral 3½ digits in addition to loss of sensation on the dorsal aspect of the same digits, that is near the nail bed. Okay, so only the distal part. So injury at the wrist, it can be due to superficial laceration at the wrist area, usually due to cut, may damage the palmar cutaneous branch only. Okay, if there is superficial laceration, so that will result in sensory loss over the skin of the lateral palm, including the thenar eminence, but there is no motor effects. If the injury or compression is due to carpal tunnel syndrome, okay, so initially if there is, mainly if it is affecting the sensory system, so initially the patient will experience symptoms like numbness, tingling, and pins and needle sensation in the lateral 3½ digits, and as if it goes on, eventually in due course there may be total sensory loss in lateral 3½ digits and also the dorsal aspect of the same digits, that is near the nail bed. Okay, but there is no sensory loss on the lateral part of the palms, that is skin of the palm, because the sparing of palmar cutaneous branch in the lesion at this level. The motor effects which can occur eventually as the symptom goes on, the condition, the lesion goes on. So there is ape thumb deformity due to paralysis of the thenar muscle, there is loss of flexion of the proximal interphalangeal joints of the fingers, and weakness of flexion of the lateral two metacarpophalangeal joint. There is also a branch called as recurrent branch, which is given at the hand area. So injury to the recurrent branch of median nerve alone produces paralysis of thenar muscles, causing ape thumb but no sensory loss, because once the median nerve exits from the carpal tunnel, okay, so it recurs back. So it gives the cutaneous branches, then it recurs back to supply the muscles of the thenar muscle, that is 3 muscles. If only that recurrent branch is affected, so it affects the motor branches, that is for the thenar muscles, but there won't be any sensory loss. So these are the different median nerve palsy at different areas and different kinds of lesions. Okay, so this is about the clinical aspects of median nerve. So that completes the anatomy and the clinical aspects of the median nerve. Thank you for watching.